Good morning everyone. We are Group B2 explaining about our topic Tryst with thyroid tumors. Our poster explains prognosis and compares types of cells found in thyroid tumor. Let's start this topic by looking at a short case scenario. A 45-year-old female presents with complaints of slowly growing mass in her neck, diarrhea, hoarseness in voice, and fatigue. The physician checks her vitals. The physician examines her neck and checks for swollen lymph nodes as well as enlarged thyroid gland. The doctor asks her to get blood tests done for T4 and T3 levels, carcinoembryonic antigen, ultrasound, and fine needle aspiration of the neck. The patient shows the report and it is found that carcinoembryonic antigen levels are increased and ultrasound of the neck shows abnormal calcifications in the thyroid gland. The FNAC shows presence of spindle-shaped malignant cells. The doctor advises the patient for total thyroidectomy and asks her to follow up after surgery.
What exactly are thyroid tumors? When we put both the words together, it makes sense for us to say that it is any kind of abnormal tissue that involves the thyroid gland. The classification of the same has, however, been very puzzling to pathologists worldwide. The latest WHO classification of thyroid tumors, which is the 5th edition released just last year, is given as follows. It's divided into developmental abnormalities, follicular cell-derived neoplasms, thyroid C-cell-derived carcinoma, mixed medullary and follicular cell-derived carcinoma, salivary gland-type carcinoma, thyroid tumors of uncertain histogenesis, thymic tumors within the thyroid, and embryonal thyroid neoplasms.
Types of thyroid tumor. Thyroid tumors are classified into types based on the nature of the cell found in the tumor. Types of thyroid tumor include 1. Differentiated thyroid cancer, 2. Anaplastic thyroid cancer, 3. Medullary thyroid carcinoma. 1. Differentiated thyroid cancer. They start in follicular cells that produce and store thyroid hormones. The cells appear similar to the normal cell under microscope. Differentiated thyroid cancers are further classified into A. Papillary thyroid cancer, B. Follicular thyroid cancer, C. Hurtle cell thyroid cancer, D. Poorly differentiated thyroid cancer.
Pathogenesis. Genes involved in follicular carcinoma are RAS point mutations, PPARG gene fusions, P13K, PTEN, and TERT. Genes involved in anaplastic carcinoma are TP53, BRAF, V600, P73, beta-catenin, RAF, and a gene named overexpressed in anaplastic thyroid carcinoma. Genes involved in papillary carcinoma are BRAF, V600E, RAS, TP53. Genes involved in MCT are M91-8T in MEN2B and C63-4R in MEN2A along with HRAS and KRAS gene. Risk factors. So females may be more prone to thyroid cancer due to hormone estrogen. Exposure to high level of radiation and inherited syndromes that increase the risk of thyroid cancer include familial medullary thyroid cancer, multiple endocrine neoplasia, and Cowden syndrome.
The clinical features are as follows. Papillary thyroid carcinoma, the patient presents with painless thyroid mass. Hoarseness and dysphagia occurs in 20% of the cases, signaling that the recurrent laryngeal nerve is involved. Thyroid function testing has limited utility in the diagnosis of PTC because most patients have normal thyroid function. Anaplastic thyroid carcinoma, here there is a rapidly enlarging, firm, fixed, and widely infiltrative neck mass, the most common symptoms being pain, breathing difficulties, dysphasias, cervical pain, and dyspnea, metastasis most frequently to lung, bone, and brain. Follicular thyroid carcinoma, it may lead to bone fracture or lung nodule. Hyperthyroidism is also documented. Medullary marker is seen. Follicular thyroid carcinoma, a painless neck mass is usually the presenting symptom. Large tumors can also lead to dysphagia or dyspnea. Hyperthyroidism is also documented in this case. Lastly, we have medullary thyroid carcinoma. Most patients in this case present with a painless thyroid mass which appears cold on scanning. 70% patients who present with the palpable thyroid nodule have cervical node metastasis, and 10 to 15% patients also present with distant metastasis at the time of diagnosis, the sites being mediastinum, liver, lungs, and bone. Upper airway obstruction and dysphagia may develop because of the tumor growth. Serum levels of calcitonin are more than 100 picogram per ml. High levels of calcitonin can lead to flushing, diarrhea, weight loss in patients. Cushing syndrome is also an uncommon symptom which is seen because of ectopic corticotropin production. CEA, carcinoembryonic antigen, is one of the most important markers for the follow-up of MTC patients and is particularly used for them whose calcitonin levels aren't that high.
Investigations. The following investigations need to be done: blood tests for tumor markers, TSH levels, genome sequencing for mutations, FNAC for identification of the type of tumor cells, ultrasound to know the structure and composition of the nodule. The ultrasonogram shows the microcalcification, and the picture below shows the fine needle aspiration cytology procedure to find the type of cells.
Papillary thyroid carcinoma. Gross features include invasive neoplasm with poorly defined margins, and calcifications may be apparent. Microscopy. Cardinal morphological features include papillae and nuclear changes. The papillae are composed of a central fibrovascular stalk covered by a neoplastic epithelial lining. The nuclei of the cells have the following abnormalities, such as change in size and shape like nuclear elongation, and irregularities of membrane like irregular nuclear contours and nuclear pseudo-inclusions. Anaplastic thyroid carcinoma. The gross features include bulky and infiltrative with a homogeneous or variegated appearance. On cross-section, zones of hemorrhage and necrosis can be observed. Microscopic features. The microscopic appearance can be broadly categorized into three patterns: sarcomatoid form, which is composed of malignant spindle cells; giant cell, which is composed of pleomorphic malignant cells; and epithelial form, which is composed of cohesive tumor nest with keratinization.
Medullary thyroid carcinoma. Microscopy. Prototypical tumor has a solid, lobular, trabecular, or insular growth pattern. Individual tumor cells are variable sized and can be round, polygonal, plasmacytoid, or spindle shaped with frequent admixtures of these cell types. Nuclei are generally round with coarsely clumped chromatin and small nucleoli. Occasional nuclear pseudoinclusions may be present. Spectrometry analysis show calcitonin as a major constituent. Occasional mucin positive vacuoles and psammoma like bodies may be available. Stromatolites, amyloid deposits are present in 90% of cases.
Management. Thyroid cancer treatment depends on the type and stage of thyroid cancer, overall health and preferences. In metastatic tumors, partial or total thyroidectomy along with neck dissection of lymph nodes is done. After surgery, thyroglobulin test, calcitonin, CEA test needs to be done to confirm if thyroid cancer has been removed. Thyroid hormone therapy after surgery includes supplementation of thyroxine hormones with regular tests to monitor level of T3 and T4. Radioactive iodine therapy is used to kill thyroid cancer cells that might remain after surgery, especially in malignancy. Chemotherapy and radiation therapy may be used to control metastasis in rapidly growing cancers such as anaplastic.